Good morning, doctors. Today we are on our 17th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy for reading for MRCGP AKT exam. And today we are at page number 390. Let's begin. Jaundice and abnormal liver function. Jaundice. Yellow pigmentation of the tissues due to excessive bile pigment. Clinical jaundice appears when serum bilirubin is more than 35 micromoles per liter. Causes. Increased production of bilirubin, prehepatic causes, hemolytic anemia, drug-induced hemolysis, malaria, Gilbert's and Crigler-Najjar syndrome. Defective processing or hepatic causes, hepatitis and cirrhosis. Block excretion obstructive causes, gallstones, pancreatic cancer, primary biliary cholangitis, primary sclerosing cholangitis, cholangiocarcinoma, sepsis, enlarged portohepatitis secondary to lymphoma. History. Patient presenting with jaundice may have no other symptoms. General symptoms include tiredness, nausea, and pruritus. Ask about color of the stools and urine. Dark urine suggests conjugated hyperbilirubinemia and hepatobiliary disease. Check alcohol consumption. Examination. Mild jaundice is best seen by the sclera in natural light. Look for signs of chronic liver disease and examine the abdomen for masses and hepatomegaly. Investigations. Initially, check the FBC and liver function test, table 12.17. Further investigations depend on the results. Management. Treatment of the jaundice. Most patients except those with Gilbert syndrome or self-limiting viral hepatitis will require specialist referral. Refer the patients with hepatic or prehepatic or hepatic jaundice to a hepatologist. Refer the patient with post-hepatic jaundice to a hepatobiliary surgeon. If aged more than 40 years plus jaundice, refer urgently to be seen within 2 weeks. Neonatal jaundice 846. Abnormal liver function. Raised AST, ALT, GGT in isolation. So only your liver enzymes are raised. Liver enzymes can be raised transiently as a result of viral infection, drugs, or alcohol. ALT tends to be more raised in viral and autoimmune hepatitis. AST tends to be more raised in patients with fatty liver. Raised GGT is associated with alcohol excess. Check medication including herbal medicines. Stop alcohol. Repeat LFTs in 1 month if AST by ALT ratio are less than 3 times the upper limit of the normal. If AST or ALT are less than 3 times the upper limit of normal, and repeat LFTs in 1 month in that time. And if LFTs are more than AST and ALT are more than 3 times the upper limit of normal, then repeat LFTs after 1 week. If still raised, request hepatitis screen and ultrasound or refer to a hepatology or gastroenterology depending on the clinical state. If ALT is less than 2 times the upper limit of the normal and hepatitis screen is negative, if ultrasound is normal, repeat the LFTs every 3 to 6 months to see if abnormalities settle. Many may be due to drugs, alcohol, or early fatty liver disease. If ultrasound scan shows fatty liver and consuming excess alcohol, advise abstinence from alcohol and check out the LFTs every 3 to 6 months. If ultrasound shows fatty liver and alcohol consumption is within normal limits, advise weight loss and low fat diet and treat metabolic syndrome and recheck the LFTs every 3 to 6 months. So in all the cases, refer for a specialist opinion. Distribution different types of jaundice. Prehepatic jaundice, hepatic jaundice, and cholestatic jaundice. Prehepatic jaundice test. Bilirubin is high. AST ALT is normal. Alkaline phosphatase is normal. HB is low in prehepatic jaundice. Hemoglobin can be low. Jaundice, mild lemon yellow jaundice. Other symptoms, urine is not darkened in prehepatic jaundice. That is unconjugated hyperbilirubinemia. In hepatic causes, bilirubin will be high. Even AST ALT will be high. Alkaline phosphate will be high, but not markedly high. Hemoglobin may be normal. Jaundice may be marked jaundice. Other symptoms are tender enlarged liver is present because it is hepatic type. Cholestatic jaundice. Bilirubin is raised. ALT/AST is mildly raised. Alkaline phosphate is very much raised. Hemoglobin may be normal. And jaundice may be marked jaundice. Other symptoms are there is an enlarged liver, itching skin, and pale stools. So itching is mostly seen in jaundice, which is conjugated, and cholestatic jaundice. A mixture picture can be confusing. Raised bilirubin. Possible causes include, so we were seeing raised liver enzymes, ALT and AST, and then how to deal with them, deal with raised liver enzymes. But now, next is raised bilirubin. Possible causes are hepatitis, biliary obstruction. If ALT or AST are raised, refer for an ultrasound scan and do a hepatitis screen, or refer for as for jaundice. So refer for an ultrasound scan, hepatitis screen, or refer as for jaundice. Hemolysis. So raised bilirubin due to hepatitis or biliary obstruction, refer as for jaundice. Hemolysis, then check for FBCs and reticulocyte count, and then refer to hematology if abnormal. Gilbert's disease. Likely if the serum bilirubin is less than 40 millimoles per liter, ALT, AST and RBC reticulocytes are normal. Bilirubin levels, that is only bilirubin is raised, rest of the ALT, AST, other liver enzymes are normal, and hemoglobin is RBC and reticulocytes is also normal. Bilirubin levels raised after fasting. So in our questions, we will have a scenario where the patient is either fasting or patient is either sick and was admitted in the hospital, and then he did not have proper food when he had only isolated raised bilirubin level. Isolated raised bilirubin levels probably still Gilbert syndrome, but refer them. Raised alkaline phosphatase usually originates from the liver or bone. Bone is more likely if serum calcium and phosphate are raised and GGT is normal or raised. May be normal. Raised alkaline phosphatase may be associated with any liver disease, but is particularly marked in patients with biliary obstruction and primary biliary cholangitis. Medications that cause raised AST/ALT. Most penicillins, especially coamoxiclav and minocycline, most of the penicillins and minocycline, antifungals, statins raise the liver enzymes, anti-epileptics, NSAIDs, some herbal medicines, some recreational drugs. Statins and abnormal liver function. Statins cause a biochemical abnormality but do not cause liver failure and are not contraindicated in compensated liver disease. May improve fatty liver disease. Measure the liver function test pre-treatment and after 1 to 3 months of statin treatment. Thereafter, measure each 6 months for 1 year. So every 6 months for a year. Discontinue if AST by ALT is raised and stays at more than 3 times the normal. Hepatitis screen. Check as appropriate. Hepatitis A, B, C serology, EBV serology, liver autoantibodies, iron studies and transferrin saturation to exclude hemochromatosis, alpha-1 antitrypsin levels, serum copper and ceruloplasmin levels if less than 40 years, alpha-fetoprotein, fasting blood glucose and lipids, HbA1c. So when you are doing a hepatitis screen, these are the tests you are supposed to be doing. Hepatitis A, B, C, EBV, liver and autoantibodies, iron studies, transferrin saturation to exclude hemochromatosis, alpha-1 antitrypsin levels, serum copper and ceruloplasmin levels, before Wilson's disease, AFP for any primary liver cancer, fasting blood glucose levels and lipids, and HbA1c levels. Fatty liver disease. Fatty liver describes the pathological process where the fat is deposited in the liver cells, but there is no inflammation or scarring. Common condition affecting up to 1 in 4 adults in the UK. Presentation. Usually it is symptomatic, asymptomatic, more than 50% patients after investigation for abnormal LFTs. Characteristic bright appearance of liver on ultrasound. Less frequently presence with a smoothly enlarged liver or symptoms. Nausea, vomiting, abdominal pain, fat embolus may be fatal. Broadly divides into two forms: alcohol associated fatty liver disease, that is AFLD, alcohol associated fatty liver disease, defined as fatty liver disease associated with daily ethanol consumption more than 20 grams in males or more than 30 grams in 20 grams in females or more than 30 grams in males. Earliest stage of alcohol related liver disease is alcoholic fatty liver disease. Affects 90% of people who drink and drink more than the recommended limits, can develop in weeks. Blood markers may be normal in alcoholic fatty liver disease. Typically the serum AST and ALT are raised, but serum AST is more than serum ALT. So both are raised, but AST is more than ALT. So ASTS is specific for alcoholic fatty liver disease. GGT may be raised in alcoholic fatty liver disease. Alkaline phosphatase may also be increased, but usually less than 2 times the upper limit of the normal. Less than 2 times the upper limit of the normal. Blood primary care management of alcoholic fatty liver disease. Identification of hazardous harmful drinking plus brief interventions to decrease the consumption. Refer to a specialist alcohol addiction service if needed. If persistent heavy drinker, males more than 35 units per week and females more than 35 units and males more than 50 units per week, refer for transient elastography to assess fibrosis or cirrhosis. So this is the next step for assessing whether there is already liver fibrosis or cirrhosis. Refer for specialist management if advanced fibrosis or cirrhosis is present. If transient elastography is not available, follow local protocols for assessment of fibrosis. Alternatively, include serum fibrosis markers, FIB4 test, fibro test or AST-ALT ratio and AST to platelet ratio index APRI. AST to platelet ratio index APRI. Repeat every 2 years. If transient elastography is not available, follow local protocols for assessment of fibrosis. Alternatives include fibrosis marker, FIB4 test, fibro test, AST-ALT ratio, AST platelet ratio index, APRI, and repeat all this every 2 years. Consider the thiamine supplements if chronic alcohol dependence is there. If severe, 200 to 300 milligrams per day has to be given, and if mild alcohol dependence is there, then you need to give 10 to 25 milligrams of thiamine per day. Prognosis. Alcoholic fatty liver disease is fully reversible and can resolve within 6 weeks with complete abstinence from alcohol. If excessive alcohol use continues, predisposed to alcoholic hepatitis and cirrhosis, which is irreversible. Alcohol misuse, we have already read about it. Chronic hepatitis, 394 and 5, we will read about it. Cirrhosis. Non-alcoholic fatty liver disease or NAFLD. This is a very hot topic nowadays in practice because we are encountering many cases with non-alcoholic fatty liver disease. Very common, affects 20 to 30% of the UK population. Prevalence has increased over the past 20 years, associated with obesity, insulin resistance, and metabolic syndrome. Screening with the liver ultrasound is not recommended except for children, young people with metabolic syndrome or type 2 diabetes. Repeat every 3 years. So you do not screen the general population because it's very common, and you screen for children or young people with metabolic syndrome or type 2 diabetes and repeat every 3 years. Blood markers of NAFLD may be abnormal. Typically, serum AST and ALT are raised, but serum ALT is more than AST. Whereas in alcoholic, AST is more than ALT. GGT may be raised. Alkaline phosphatase may be raised, but usually less than 2 times the upper limit of the normal. Complications. A high proportion develop diabetes long term. More severe disease results in non-alcoholic steatohepatitis NASH. 12% with NASH develops cirrhosis. Complications. High proportion develop diabetes in the long term. More severe disease result in non-alcoholic steatohepatitis, NASH. 12% with NASH develop cirrhosis. So these are all predisposing to liver cirrhosis. Assessment of fibrosis. Once NAFLD has been diagnosed, assess for fibrosis using the enhanced liver fibrosis test. So this is one test which is available for non-alcoholic fatty liver disease, but this is not available for alcoholic fatty liver disease, if available. Alternatives include the FIB4 test, the NAFLD score, or the transient elastography. Referral for specialist assessment. Child or young person with suspected NAFLD on ultrasound. Any age with significant liver fibrosis risk. Example, the ELF score is more than 10.51. That is, enhanced liver fibrosis test score is more than 10.51. Management in primary care. Lifestyle advice. Low fat diet, weight loss, increased exercise, decreased alcohol. So you have to take a low fat diet, reduction of weight, increase exercise and decrease the alcohol. Consider referral for bariatric surgery if meets local referral criteria. Repeat ELF test. This is enhanced liver fibrosis test or other fibrosis score every 3 years. You have to repeat it. Drug treatment. Not usually indicated in primary care. In secondary care, treatment with metformin, pioglitazone, or a vitamin E may be considered. Treatment with statins is ineffective. So, for NAFLD, you need to refer, and you cannot initiate the treatment in primary care. But these are the treatments: metformin, pioglitazone, or vitamin E. Rarer causes of fatty liver disease. Drugs like amiodarone, tamoxifen, and valproate. Malnutrition, inflammatory bowel disease, and pregnancy are the other causes of fatty liver disease. Hepatitis. Page number 394. Acute hepatitis may be asymptomatic or present with fatigue, flu-like symptoms, fever, light stools, dark urine, and/or jaundice. Causes are light stools, dark urine, or jaundice, and flu-like symptoms. Causes are viral hepatitis, HBV, HAB, and EBV, alcohol, drugs, diclofenac, coamoxiclav, toxins, obstructive jaundice, other infections, malaria, Q fever, leptospirosis, and yellow fever. Management. Check the LFTs, the FBC, the urine routine, EGFR, hepatitis serology. Treat the cause. Admit if condition is poor or rapidly deteriorating. Refer for investigation if sustained abnormalities in liver function with unclear cause. Complications are chronic hepatitis, acute liver failure, if you are not treating it. So hepatitis A, HAV. Common. Spread is by fecal-oral route. Patients are infectious 2 weeks before feeling ill. Incubation period is 2 to 7 weeks. Average is 4 weeks. High risk groups. Travelers through high risk areas, institutional inhabitants and workers, IV drug abusers, and patients with high risk sexual practices are high risk. May be asymptomatic, especially in young people, or present with fever, malaise, fatigue, anorexia, nausea, vomiting, abdominal pain, diarrhea, tender hepatomegaly, and pale stools, dark urine, or jaundice. 78 to 80% of the adults. Management. Check the LFTs, hepatic jaundice, and hepatitis serology. IgM antibodies signify recent infection. Immunity follows infection, and IgG remains detectable lifelong. Management is supportive. Avoid alcohol until LFTs are normal. Most recover in less than 2 months. Hepatitis A does not cause chronic liver disease and there is no carrier state. Prevention. Vaccination is indicated for travelers to high risk areas, people with chronic liver disease, or those working in high risk situations. Vaccination is available. Indicated. Preparations available include the monovalent vaccine or Havrix. Hepatitis A and B combined vaccine is Twinrix. Hepatitis A and typhoid combined vaccine is Hepatyrix. Passive immunization with immunoglobulin gives protection for less than 3 months and is used for short-term travel or protecting household contacts or sufferers. So this is passive immunization with human immunoglobulin for protection for less than 3 months, used for short-term travel, protecting household contacts of the sufferers. Hepatitis E virus. Similar to hepatitis A virus, usually acquired in developing countries, incubation period is 2 to 9 weeks, average is 40 days, and diagnosis is made with serology. Treatment is supportive, and there is no chronic state. Mortality in pregnancy can be as high as 20%. No vaccine exists for hepatitis E. Hepatitis B we will see in page 718, hepatitis C in 718. Chronic hepatitis. Chronic hepatitis is hepatitis lasting more than 6 months, may be asymptomatic or present with fatigue, right upper quadrant pain, jaundice, arthralgia, signs of chronic liver disease, gynecomastia, testicular atrophy, clubbing, palmar erythema, leukonychia, peripheral edema, spider nevi, and portal hypertension. Recurrent infections or complications, acute liver failure, cirrhosis, hepatocellular carcinoma. Causes are viral hepatitis, alcohol, drugs, nitrofurantoin, methyl dopa, isoniazid, drugs causing chronic hepatitis. Chronic autoimmune hepatitis, primary biliary cirrhosis, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, and sarcoidosis. Management is first check the LFTs, then FBC, then UNE, then EGFR, and then hepatitis screen. Refer for a specialist care. Chronic autoimmune hepatitis, also known as chronic active hepatitis, typically young women, associated with personal family history of autoimmune diseases like rheumatoid arthritis or vitiligo. Diagnosis is confirmed with liver biopsy and autoimmune markers. Specialist management is with steroids plus immunosuppressants. Primary biliary cholangitis, slow progressive cholangiohepatitis eventually resulting in cirrhosis. Cholangiohepatitis eventually resulting in cirrhosis. Females more than males, 9:1 ratio. Peak age at presentation is 45 years. Process probably autoimmune. Associations with thyroid disease, Sjogren's syndrome, Crest syndrome, celiac disease, hepatic, extrahepatic malignancies, and pancreatic hyposecretion. This is primary biliary cholangitis. Presentation 50% are asymptomatic. At presentation, symptoms and signs of fatigue, pruritus, because biliary cause is pruritus is more prominent, arthralgia, osteoporosis, osteomalacia, hirsutism, obstructive jaundice late, symptoms or signs of cirrhosis or liver failure. Investigations and management. In blood, you do the LFTs. If raised, alkaline phosphatase will be there because biliary cholangitis. So alkaline phosphatase is raised, ALT is raised, GGT is raised. Liver biopsy is diagnostic. Refer for a specialist care. If symptomatic, 1 in 3 remain symptom free. The rest develop symptoms in 2 to 4 years. Median survival is 7 to 10 years. Liver transplant is an option in primary biliary cholangitis. Prognosis following transplant is good, but recurrence may occur in the transplanted liver. So if they are asymptomatic, they develop symptoms in 2 to 4 years. And liver biopsy is diagnostic but refer to a specialist care if they are symptomatic. We are at page number 396. Liver failure and portal hypertension. Acute liver failure presents with sudden onset severe illness. Presence with sudden onset severe illness, jaundice, hypoglycemia, hepatic encephalopathy, ranges from mild confusion and irritability through drowsiness and increased confusion to coma. Hemorrhage due to deranged clotting factors, ascites, hepatosplenomegaly. Ascites are not usually prominent. Infection, nausea and vomiting, raised BP, fetal hepatitis, sweet smell on the breath. These are symptoms of acute liver failure. Causes of acute liver failure. Causes in a previously healthy person. It could be viral hepatitis, Weil's disease, paracetamol overdose, halothane, idiosyncratic drug reactions, fungal or plant toxins, malignant infiltration, chemical exposure like carbon tetrachloride, heat stroke, Budd-Chiari syndrome, pregnancy, Wilson's disease, Rice syndrome. In a patient with chronic liver disease, infection, bleeding, GI bleeding, sedation, diuretics or electrolyte imbalance, alcohol binges, and constipation can lead to acute liver failure. Management. Admit as an emergency unless an expected terminal event is there. Poor prognosis is poor, less than 60% survive in acute liver failure. Cirrhosis. The liver is replaced by fibrotic tissue and regenerating nodules of hepatocytes. Common causes of cirrhosis are hepatitis B infection, alcohol misuse, hepatitis C infection, type 2 diabetes or BMI more than 30 kg per meter square. Screening high risk groups. Offer a transient elastography if chronic hepatitis B or C infection, retest every 2 years or more frequently according to the specialist advice. So, screening high risk groups, these are high risk groups, and when you have to, how often you have to screen them. You have to screen with a transient elastography, TE, for chronic hepatitis B and C every 2 years or more frequently due to specialist advice. Persistent heavy drinker who is still drinking in spite of having a abnormal liver function test, and in that case, females more than 35 units or males more than 50 units, or confirmed alcohol related liver disease, retest every 2 years. So there's a confirmed alcoholic fatty liver disease. Every 2 years you have to retest with transient elastography. That non-alcoholic fatty liver disease plus advanced fibrosis, enhanced liver fibrosis test score more than 10.51, retest every 3 years. Liver biopsy is an alternative if TE is not suitable. If transient elastography is not suitable, you do a liver biopsy. Do not use liver function blood test to rule out cirrhosis. Presentation of acute liver failure. Variable. Maybe an incidental find. I think this is chronic liver failure. No. Liver failure as such. So presentation is variable. Maybe an accidental finding with no symptoms, may be present with non-specific symptoms like weakness, fatigue, lethargy. Specific symptoms or signs of liver failure is hepatomegaly, but liver becomes small and hard in later stages, spider nevi, diputeraneous contracture, palmar arrhythmias, gynecomastia, testicular atrophy, clubbing, xanthelasmia and xanthomata, portal hypertension, splenomegaly. Late signs occur when the liver can no longer compensate for the damage to it is jaundice, hepatic encephalopathy in decompensated liver. jaundice, hepatic encephalopathy, leukonychia, edema due to hypobilirubinemia. Management: refer to gastroenterology or hepatology for expert advice. Treat with the cause where possible. Avoid alcohol completely and refer to a dietitian for advice on nutrition. Pruritus secondary to jaundice may respond to cholestyramine. Give pneumococcal vaccination and annual influenza vaccination. Complications are portal hypertension plus bleeding esophageal varices, encephalopathy, hepatocellular carcinoma, ascites, bacterial peritonitis complicates 1 in 4 cases. Consider the prophylaxis with ciprofloxacin. Renal failure. So subacute bacterial peritonitis in a patient with ascites, consider prophylaxis with ciprofloxacin. Renal failure. Prognosis very variable depending on the age, the cause, the willingness to modify contributing lifestyle factors. Portal hypertension. Portal venous pressure is raised due to obstruction of the portal system before, within or after the liver. In Western countries, the most common cause is cirrhosis, elevated portal venous pressure, the collaterals between the portal and systemic circulation including the esophageal varices, usually presents with hematemesis or melena from bleeding varices. Ascites develops if there is coexistent liver failure with hypoproteinemia and hyperaldosteronism. Splenomegaly is common, thrombocytopenia and leukopenia. Signs: splenomegaly, ascites, dilated veins around the umbilicus is rare, purpura. Signs of chronic liver disease. After the diagnosis of cirrhosis, offer upper GI endoscopy to detect esophageal varices. Repeat every 3 years if negative. So you have to repeat endoscopy for esophageal varices screening every 3 years. Refer to gastroenterology or hepatology. Specialist management is essential. If GI bleeding, refer as a blue light emergency. If there's a GI bleeding, refer as a blue light emergency. Hepatocellular carcinoma 398. So page number 398. Other liver diseases. Gilbert syndrome. So Gilbert syndrome is an inherited metabolic disorder causing unconjugated hyperbilirubinemia. Prevalence is 1 in 2%. Onset is shortly after birth, but the condition may go unnoticed for years. Jaundice occurs during intercurrent illness. Increased bilirubin on fasting can be confirmed diagnosis. Liver biopsy is normal. No treatment is required and prognosis is excellent. Primary hemochromatosis. Hemochromatosis is an autosomal recessive condition of excess gut absorption of iron, iron deposition and damage to the heart, the liver, the pancreas, the joints and the pituitary. Near about 400 people are homozygous for this condition, but expression is highly variable. Males more than females. Females present 10 years later than males. Often an incidental finding or found by screening relatives of affected individuals, genetic testing or serum ferritin levels. Symptoms or signs: tiredness, hepatomegaly plus or minus signs of cirrhosis, impotence or testicular atrophy, arthralgia or arthritis, skin pigmentation, diabetes, cardiomyopathy. Investigations and management. Blood. There is raised ferritin, raised iron, transparent saturation is more than 70%, total iron binding capacity is reduced, refer, liver biopsy is diagnostic, venesection returns life expectancy to normal. Secondary hemochromatosis. Iron overload from frequent transfusions for hemolysis. Specialist management with chelation therapy to increase the iron excretion is required. Alpha-1 antitrypsin deficiency is an autosomal recessive disorder. Defective alpha-1 antitrypsin production leads to lung and more rarely liver damage. Treatment with IV alpha-1 antitrypsin decreases the progression of COPD. Paracetamol may protect the liver. Encourage the use for minor illness. Liver transplantation may eventually be needed. Wilson's disease, hepatolenticular degeneration, a rare autosomal recessive disorder, defective biliary copper excretion defective biliary copper excretion leading to accumulation of copper in the liver, the brain, the kidney, and the cornea. Treatment is with penicillamine. Liver transplantation is the only treatment if presentation is with acute liver failure. Benign tumors. Hepatomegaly plus right upper quadrant pain or an incidental finding. Common types are hepatic adenoma, fibroma, leiomyoma, lipoma, hemangioma, focal nodular hyperplasia with cirrhosis. Management is refer for gastroenterology to exclude malignancy and confirm the diagnosis. Urgency depends on the clinical picture and ultrasound findings. Hepatocellular carcinoma is rare in the UK, 100 new cases and 100 deaths per year. Much common in the areas of the world where hepatitis B is endemic, China and India. Usually arises from regenerating nodules in the cirrhotic liver. Peak age is 60 to 70 years. Intra and extrahepatic spread is common and occurs early. So HCC is more common in areas where hepatitis B is endemic like India and China. Usually arises from regenerating nodules in cirrhotic liver. Peak age is 60 to 70 years. Intra and extrahepatic spread is common. Surveillance. All patients with confirmed cirrhosis should have a regular ultrasound scanning surveillance. Usually this is specialist led. Presentation. In a patient with cirrhosis, fatigue, fever, anorexia and weight loss, ascites. Rapid deterioration in liver function. Already a patient has cirrhosis and he presents with fatigue, fever, anorexia or weight loss, ascites, rapid deterioration liver function, hemorrhage into the peritoneal cavity, often fatal, Budd-Chiari syndrome, occlusion of the hepatic vein resulting in jaundice, epigastric pain and shock. Examination may reveal an abdominal mass, hepatomegaly, plus or minus an arterial bruit over the tumor. Management. If suspected, check the AFP levels and refer for urgent assessment. AFP more than 500 nanograms per ml in a patient with known cirrhosis is almost certainly diagnostic. The most important prognostic factor are the number and size of the liver lesions and the presence of vascular involvement. 95% patients with cirrhosis have a disease too extensive for curative surgery or their severely compromised liver function makes radical surgery inappropriate. 50% of patients without cirrhosis have resectable tumors. Surgery may be combined with liver transplantation. Inoperable tumors may be treated with hepatic artery ligation or emboligation. Tumors respond poorly to chemotherapy or radiotherapy. Overall prognosis. Patient with cirrhosis, median survival is 3 months. Patients without cirrhosis, median survival is only 1 year. Is 1 year, and this is 3 months, is very less. Cholangiocarcinoma is a rare adenocarcinoma of the biliary tract, may be associated with ulcerative colitis. Typically presents more than 60 years with jaundice, right upper quadrant pain and weight loss. The only effective treatment is surgery, which is only possible in 10 to 20% patients. Selected fit patients with unresectable disease may be offered palliative chemotherapy or enrollment in a clinical trial. Median survival is 4 to 6 months. Secondary tumors. The most common type of liver tumor is secondaries, usually signaling a late disease. Presentation: hard, enlarged, knobby liver, plus or minus right upper quadrant pain, plus jaundice, which is late. If found and no history of malignancy, refer to oncology or general surgery for urgent referral to find the primary. Primary tumors commonly metastasizing to the liver are lung cancer, breast cancer, large bowel cancer, stomach cancer, uterine cancer, pancreas, carcinoid, lymphoma or leukemias. Gallbladder disease, page number 400. Gallstones. Gallstones are increasingly common. 9% of the 60-year-olds have them and prevalence is increasing with age. Other features are Gender, females have more than males. Body weight, prevalence is increased with weight, also associated with rapid weight loss. Race, in the US and Native American, Hispanic common, and more than Hispanic, more than white, more than black. Affluency, increased risk. Pregnancy, post, possibly hormone replacement therapy but not COCP. Pregnancy, hormone replacement therapy but not COCPs. Alcohol is protective. Diet, vegetarian diet is protective. Associations of gallbladder disease, conditions, associated conditions of gallstones, hemolysis, diabetes, hypertriglyceridemia, cirrhosis, Crohn's disease, and partial gastrectomy. Drugs which cause gallstones, clofebrate and other fibric acid derivatives, octreotide, which is a somatostatin analog. These are the two drugs which cause gallstones. Presentation. Gallstones are blamed for many digestive problems. They are probably innocent in most cases. 70% of stones in the gallbladder do not cause any symptoms. Common presentations in table 12.18. Management of gallstones. Advise the patient to stick to a low-fat diet. Refer for surgical review plus or minus further evaluation. Example, ERCP, endoscopic retrograde cholangiopancreatography. Gallstones can be removed by cholecystectomy, laparoscopic or open, or ERCP, or may be dissolved with ursodeoxycholic acid. Stones less than 5 mm in diameter, 40% recur in less than 5 years. Dissolved with ursodeoxycholic acid. Stones less than 5 mm in diameter, 40% recur in 5 years. Or shattered with a lithotripsy, 1 in 3 people develop biliary colic afterwards. Persistent digestive symptoms after surgery are common. 50% after cholecystectomy are difficult to treat. Gallbladder cancer is rare. Females more than males. Gallstones are predisposing factor, typically present in patients more than 40 years with right upper quadrant pain, anorexia, weight loss, and jaundice. Refer for a specialist upper GI assessment to be seen in less than 2 weeks if suspected. Surgical resection offers the only hope, but cure of disease is usually advanced. Hope of cure, but disease is usually advanced at presentation. Selected fit patients with unresectable disease may be offered palliative chemotherapy or enrollment in clinical trial. Prognosis is poor. Presentation and management of gallstones. Presentation, biliary colic. Management. Clear-cut attacks of severe abdominal pain which may radiate back to the back or to the shoulder tip, lasting more than half an hour, causing restlessness plus jaundice plus nausea or vomiting. Examination, there is tenderness and guarding in the right upper quadrant, increase on deep inspiration which is called the Murphy's sign. Management, treat acute attacks with betadine, 50 mg IM PO or diclofenac, 50 to 100 mg IM PO or PR, plus prochlorperazine, 12.5 mg IM or domperidone, 10 mg PO for nausea. So you either give betadine or diclofenac plus prochlorperazine or domperidone. Admit if uncertain of the diagnosis, inadequate social support, persistent symptoms despite analgesia, suspicion of complications or concomitant medical problems, example dehydration, pregnancy, diabetes or Addison's. Investigate for gallstones with abdominal ultrasound to prove diagnosis when settled. A differential diagnosis may cause acute abdomen. Differential diagnosis, any cause of acute abdomen. Treat the gallstones to prevent recurrence. That is biliary colic. Acute cholangitis or cholecystitis. Pain and tenderness in right upper quadrant or epigastrium plus vomiting. Examination, there is tenderness plus guarding in the right upper quadrant plus or minus fever and jaundice. Treatment, broad spectrum antibiotic like ciprofloxacin plus analgesia as for biliary colic. So acute cholangitis or cholecystitis treatment. Broad, it's broad spectrum antibiotic because it's acute infection of the gallbladder or the bile duct. So broad spectrum antibiotic, that is ciprofloxacin, and analgesia as for biliary colic. So in biliary colic there is no infection. So you only give analgesia and anti-vomiting drugs, anti-emetic drugs. But in acute cholecystitis or cholangitis there is a infectious component. That is why you will give broad spectrum antibiotics and analgesia as for biliary colic. Admit if generalized peronism is present. Diagnosis is uncertain, very toxic patient, concomitant medical problems are there like dehydration, diabetes, Addison's or pregnancy, inadequate social support or not responding to medication. Empyema occurs when there is obstructed gallbladder fills with pus. Presence with persistent swinging fever or pain. So this is swinging fever is characteristic of any kind of pus deposition in the body in the form of abscess, empyema, emphysema, etc. Usually requires cholecystectomy plus surgical drainage. Investigate and follow up to prevent recurrence as for biliary colic. Pancreatitis, page 402. Gallstone ileus occurs usually after an attack of cholecystitis. A stone perforates from the gallbladder into the duodenum and impacts in the terminal ileum, causing bowel obstruction. Chronic cholecystitis is a vague intermittent abdominal discomfort, nausea and flatulence and intolerance of fats. Investigate for gallstones with abdominal ultrasound to prove the diagnosis. Differential diagnosis is could be a reflux, could be IBS, could be upper abdominal GI tumor or PU. Refer for treatment of gallstones. Jaundice. Cholestatic jaundice, page 390, plus right upper quadrant pain. Symptoms of cholestatic jaundice plus right upper quadrant pain. Page number 402, pancreatitis. Acute pancreatitis. Premature activation of the pancreatic enzymes leads to autodilution and tissue damage. Most episodes are mild and self-limiting, but 1 in 5 patients have a severe attack. Overall morbidity is 5 to 10%, may be recurrent. Causes in 10% of the patients, there is no cause is identified. Common causes are 80%. Causes are gallstones or alcohol. Rarer causes are drugs, azathioprine can cause pancreatitis, trauma, pancreatic tumors, post-ERCP cases, viral infection, mumps, HIV and Coxsackie virus, mycoplasma infection, hypercalcemia, hyperlipidemia, pancreas divisum, normal variant in 7 to 8% of the white population, familial pancreatitis, vasculitis, ischemia or embolism, pregnancy and end-stage renal failure. Presentation. Poorly localized, continuous boring epigastric pain which increases over 1 hour and often worse on lying down plus radiating to the back. Nausea and vomiting is present. Examination. Tender, tachycardia, examination general, tachycardia, fever, shock and jaundice, abdominal, local epigastric tenderness or generalized abdominal tenderness, abdominal distension, plus or minus bowel reduction in bowel sounds. Evidence of retroperitoneal hemorrhage is present. Periumbilical and flank bruising is rare. Admit. Management. Admit as an acute surgical emergency. Prior to transfer, give analgesia with petidin. Morphine may induce spasm of the sphincter of OD. So you are not giving morphine. You will give petidin for analgesia. Complications. Delayed complication may present in general practice. Suspect if persistent pain or failure to regain weight or appetite. Complications include pancreatic necrosis, pseudocyst, localized collection of pancreatic secretions, fistula or abscess formation, bleeding or thrombosis. Prevention of further attacks of pancreatitis. Avoid factors that may have caused pancreatitis like alcohol or drugs. Advise patients to follow a low-fat diet. Treat the reversible causes like hyperlipidemia and gallstones. Chronic pancreatitis. Chronic inflammation of the pancreas results in gradual destruction and fibrosis of the gland, plus or minus loss of pancreatic function, leading to malabsorption and diabetes. Causes are: alcohol is responsible for most of the cases of chronic pancreatitis. More rarely, a familiar cause like cystic fibrosis, hemochromatosis, pancreatic duct obstruction by gallstones or pancreatic cancer, and hyperparathyroidism can cause chronic pancreatitis. Presentation: constant or episodic epigastric pain radiating to the back relieved by sitting forwards, vomiting, weakness, jaundice, steatorrhea, weight loss, diabetes, and chronic poor health. Management: refer to gastroenterology. Treatment: diet: low fat diet, high protein content, high calorie diet. See, this was a specific question asked. Low fat diet, high protein diet, and high calorie diet with fat soluble vitamin supplements. Refer to a dietitian. So fat soluble vitamins are ADEK. So you're supplementing ADEK, giving a high calorie diet and a high protein diet but low fat diet, along with pancreatic enzyme supplementation, that is Creon capsules pre-meals may improve diarrhea. Alcoholic abstinence, pain control, provide analgesia, beware of opioid use, consider referral to celiac plexus block. Surgery, pancreatectomy or pancreaticogynostomy for pancreatic duct stricture, obstructive jaundice, unremitting pain or weight loss. Diabetes management, pancreatic insufficiency. Global reduction in function of the pancreas. Causes are in a child, cystic fibrosis; in an adult, chronic pancreatitis, pancreatic tumor, pancreatectomy or total gastrectomy. So causes of pancreatic insufficiency in a child is cystic fibrosis, whereas in adults either due to chronic pancreatitis or there is a pancreatic tumor or there is a pancreatectomy was done or total gastrectomy was done. Presentation: malabsorption, frequent loose odorous stools plus abdominal pain, weight loss or failure to thrive, and diabetes. Management: take a specialist advice, treat the underlying cause and also associated diabetes, supplement digestive enzymes with Creon. Pancreatic tumors. Pancreatic cancer accounts for 3% of all malignancies, causing 7,800 deaths in the UK per year. 80% of the cases occur in patients more than 60 years. So, males more than females, pancreatic tumors. Risk factors of pancreatic cancer: smoking causes 25 to 30% of pancreatic cancers in the UK. Risk returns to non-smoker levels 10 to 20 years after cessation of smoking. Chronic pancreatitis, usually related to excess alcohol. Type 2 diabetes, relative risk is 1:8. Obesity increases risk by 19%. Genetic causes: 5% pancreatic cancers are hereditary, characterized by presentation of in age less than 30 years or a positive family history. Occupation: the cancer is raised among nickel workers and workers exposed to insecticides, radiation, lead, iron or chromium. Lead, iron and chromium, and radiation and insecticides, and nickel workers. Tumor characteristics: the majority of the pancreatic tumors develop in the exocrine part of the gland. 95% of tumors are adenocarcinomas. Rarely tumors develop from the endocrine part. These have better prognosis. 75% arise in the head of the pancreas, 15% from the body and 10% from the tail. Tumors arising from the head of the pancreas tend to be present earlier and are easier to remove. Spread to local lymph nodes occur early, and metastatic spread to the peritoneum, liver, lungs is frequently found at presentation. So early metastasis. Presentation: non-specific with gradual deterioration of health or fatigue, anorexia or weight loss. Pain in the epigastric region plus radiation to the back may be relieved by sitting forward. Diarrhea and steatorrhea due to malabsorption. Early satiety, dyspepsia or nausea, vomiting, gastric outlet obstruction. Obstructive jaundice. Picture: pancreatitis New diabetes, spontaneous venous thrombosis. Examination. Check for weight loss, epigastric or upper quadrant mass, hepatomegaly or jaundice. If jaundice is present, the gallbladder may be palpable as a small rounded mass beneath the liver. So this is a painless enlarged gallbladder just below the liver. Primary care management. Refer for non-urgent assessment in less than 2 weeks to a team specializing if upper GI cancer. Refer for urgent assessment within 2 weeks to a team specializing in upper GI cancer if upper abdominal mass consistent with pancreatic cancer and aged more than 40 years plus jaundice. For direct access CT or ultrasound if CT is not available, if patient is more than 60 years and there is weight loss and more than one of the following symptoms like diarrhea, there is a back pain, abdominal pain, nausea, vomiting, constipation or new onset diabetes. Any of these. For direct access ultrasound, if upper abdominal mass consistent with enlarged liver or gallbladder. Specialist management. Diagnosis is confirmed using a combination of ultrasound, CT scan, MRI and ERCP. Only potentially curative treatment is surgery, but less than 15% are suitable for surgery at presentation. The operation of choice is Whipple's procedure, pancreaticoduodenectomy. Surgery is associated with significant morbidity. Mortality is 5 to 10%. Prognosis. Those undergoing surgical resection have 5-year survival of 7 to 25%. Median survival is 11 to 20 months. But those that survive 5 years are likely to survive long term. Median survival for those with irrespective of locally advanced disease is 6 to 11 months and 2 to 6 months if metastatic disease. So it is very poor prognosis cancer. Palliative treatment. Patient with locally advanced or metastatic disease may benefit from surgical bypass or common bile duct or duodenal obstruction. Surgical bypass of the common bile duct or the duodenal obstruction. So there's a common bile duct obstruction in pancreatic cancer that is causing the jaundice. So once you bypass it, the jaundice will be relieved or duodenal obstruction can be relieved. An alternative is biliary stenting. Chemotherapy may give some survival benefit. Refer for palliative care support early. So this is for people who cannot tolerate the surgery or who are not interested in the surgery because of very poor survival rates and risk of surgeries. Endocrine tumors. In all cases, specialist management is required. Glucagonoma. Islet cell tumor of the pancreas. Most are malignant. 90% have liver or lymph node metastasis at presentation. 5 to 20% of tumors occur as a part of MENS, multiple endocrine neoplasia syndrome 1, presenting with attacks of hyperglycemia. Diabetes is more than 50% cases. Skin changes in glucagonoma. Sore mouth, necrolytic migratory erythema 70%, a rash which starts as an erythematous rash, then blisters before crusting. Weight loss and cachexia, tendency to venous thrombosis, anemia, diarrhea, and depression or psychosis. Insulinoma. Tumor of the APUD cells of the islets of Langerhans. 90% are benign. 7 to 8% are associated with MENS syndrome. Even insulinomas are associated with MENS syndrome. Presents with episodes of hypoglycemia, especially when exercising or fasting, and increased appetite for frequent food intake to avoid hypoglycemia often results in substantial weight gain. Somatostatinoma. Uncommon islet cell tumor. Most are large tumors more than 5 centimeters in the head or body of the pancreas. Presents with gallstones and steatorrhea and diabetes. Extrapancreatic somatostatinomas can present in association with neurofibromatosis type 1 or pheochromocytoma. These are extrapancreatic somatostatinomas with neurofibromatosis type 1 or pheochromocytoma. Werner-Morrison syndrome is an intestinal vasointestinal peptide VIP producing tumor resulting in profuse watery diarrhea leading to dehydration and metabolic acidosis and reduction in potassium levels. Also associated with insulin resistance and impaired glucose tolerance. VIPomas account for less than 10% of islet cell tumors, 60% are malignant. Werner Morrison syndrome. So that's all for today, friends, and tomorrow we will continue to the next chapter, renal medicine and urology, page number 407. Thank you. Have a good day.